All right, so let's get started with a little bit of the background information. I don't think I need to drive this point home to this group. I think you all, unfortunately or fortunately, are intimately aware of how atrocious pancreatic survival rates are in 2020. This is actually surprisingly an improvement over the course of the last few years, where even just 5 years ago, we were averaging a 5-year survival rate in the 5 to 6% rate. We're now up to 10%, but clearly have a very long way to go. Another way of looking at this 10% 5-year relative survival is that of these 100 individuals depicted in this schematic here, only 10 of them will be alive 5 years down the road. And obviously those are unacceptable, sobering statistics. And as you all likely know, the survival of this disease really depends significantly on the time or the stage at which this disease is discovered. Unfortunately, only 11% of people diagnosed with pancreatic cancer have localized disease, which means disease confined to the pancreas. The overwhelming majority of patients have either regional spread or distant spread, meaning the cancer has metastasized. And again, survival rates vary significantly depending on what stage of the disease we're able to make this diagnosis at. And so I think this cartoon really captures for us, the medical community, how we feel about things. So this is us, the medical community here, and we've been showing up and we've been playing the game for the past 20 years or so. And unfortunately, we're still coming up incredibly short. And obviously, that's not enough. We want to do better than we've currently been able to do. I want to take just a brief second to give you just a very simplistic anatomy lesson. And I think the point behind the schematic is just to highlight for you why this is such a difficult disease to treat. This is the pancreas here. I don't know if you're able to see my cursor. Maybe so. This tan organ here in the middle of your screen. And you can see how intimately connected to the vasculature in the abdomen, the bile duct, to the intestine, how connected the pancreas is to all of these critical structures in the belly. And so I think this drives the point home. If you have a lesion in the pancreas, because of its connection and its attachment to these other organs, resection of these tumors is frequently very, very difficult. The symptoms of pancreatic cancer don't really help us a whole lot, unfortunately, in getting to a diagnosis early. So these are incredibly vague symptoms: abdominal pain, nausea, weight loss, loss of appetite. And again, because these symptoms are so vague, they're frequently attributed to a variety of other etiologies, a variety of other causes, and also lead to a delay in diagnosis. It's frequently not until a patient becomes jaundiced, where their eyes turn yellow, that they present to medical attention. And frequently, I know some of us on this call know this from personal experience, unfortunately, by that time, frequently it's too late for us to be able to do anything. So who's at risk? I think this is an important message for everyone as we think about pancreatic cancer. So if you look across the general population, the risk of developing pancreatic cancer is really only about 1%. And that's a relatively small number when you compare it, or a relatively low number when you compare it to other cancers like breast and colon. But with that said, there are certainly patient populations or individuals who are at increased risk. And that population is really comprised of 3 different categories of individuals. Individuals with certain types of pancreatic cysts, patients with certain genetic conditions which put them at increased risk, and patients with a family history of pancreatic cancer. And in 2020, because our medical treatment options are really so abysmal and so disappointing, our goal from the pancreatic cancer prevention standpoint is really to identify these high-risk lesions and intervene before a cancer ever develops. So what sort of hope is there out on the horizon? This picture is actually, I don't know if any of you have ever been out to Bryce Canyon. It's just breathtaking, one of my favorite places in the US. So offering hope. The Pancreatic Cancer Prevention Program was launched by John, myself, and a number of our other colleagues back in 2016, again, with the goal of really identifying these high-risk individuals, screening these individuals, and offering an opportunity to identify high-risk lesions before they ever go on to develop into a cancer. Our program is really a multidisciplinary effort comprised of surgical oncologists like John, gastroenterologists like myself, dedicated abdominal radiologists, members of the cancer genetics team, and all individuals who truly, to their core, are committed to preventing this disease from having the devastating effects it's had on so many individuals. So we have a robust research arm to the program in addition to the clinical work that we do. Our research focus is really focused on the early detection of pancreatic cancer. And so individuals, as they enter into the program, have a great deal of demographic data that they contribute to the program. We ask all sorts of questions about prior family history, factors that you may not consider important, but links that we are trying to establish for those members entering into our program. The research arm of things also is supported by the blood that we're able to collect on our patients and cyst fluid that we're able to collect anytime we perform an endoscopic ultrasound. We're able to bank pancreatic cyst fluid to serve potentially down the road as a platform for biomarker identification. So allowing us to say, this individual had this biomarker or this finding in their pancreatic cyst fluid, and they went on to develop a tumor versus this other individual who did not. And so really allowing us to apply this broadly across all of the individuals who come into our program. To date, we've seen over 2,000 patients since 2016, and that number continues to grow at a breathtaking pace. There is demand for weeks to months out as far as getting in to see us, which is a fantastic position for us to be in. We are seeing patients across the country, not just in the Metroplex, but we're able to do telehealth visits and really provide this service to individuals in neighboring states and really all over the country at this point. I think with that, this is a picture of some of the key members of our team. There are countless other individuals who really make what we do continue to be possible. They're not all captured in this picture, but we have lots of people on this campus working towards advancing the field and preventing pancreatic cancer from being the deadly disease it has been for so long. Again, I want to turn this over to my colleague now and let him give you a little bit more information, but I can't say thank you enough for everything that it is you guys are doing to support the work that we are doing. Oh, John, I think you're still muted. I can't hear you.
Thanks, Nisa. I like that I could see people clapping.
Yeah.
Nicely done there. That's well done. So, you know, I think it's such a great setup, Nisa. And I think this concept that we repeat a lot in clinic when we talk to patients is that our goal is not to identify patients with early stage cancer. That's actually not our goal. Our goal is to identify patients right before they develop cancer or before they actually have it. And you know, we're in the process. We commonly say that we don't want to have people be pancreas cancer survivors. We want them to never have had the disease, and that's really what I think is very different about what we're trying to do. Doesn't mean that we don't have strategies to try to treat patients with early stage pancreas cancer and late stage pancreas cancer. But we think this is a very unique opportunity to impact those curves and really impact these patients. And so what Nisa and I thought we would do is talk through at least one of the most common reasons that we see patients, which is pancreas cysts, and just give you a little bit of an introduction, a little primer about what these cysts are like, how we take care of them, and what our rationale is for treating patients and studying these diseases. So I say to patients that having a pancreas cyst is not uncommon. If you just went out to the street and stopped adults and scanned them, did a scan, you'd find that somewhere around 20 to 25% of people will have a cyst. And people have big cysts, people have little cysts, and for the vast majority of patients, well over 90% of patients with pancreas cysts, they will not develop pancreas cancer. And so the question is, how do we identify that small group of people who have pancreas cysts who are at risk for transitioning into a cancer? And that's a little bit about what we're going to try to introduce here. What this slide is showing is a CAT scan. And what you see on this scan is, many of you have probably looked at scans. This thing over here is, oh yes, Nisha's got the marker. That thing right there is the cyst that she's showing, that sort of grayish thing that is in the tail of the pancreas. That, by any measure, is a pretty big cyst, and we've picked a picture that shows this pretty dramatically. That cyst is probably 7 centimeters or so. We very frequently see centimeters that are well under half that size. So that's the kind of thing that we're talking about. And even a cyst that's that size can oftentimes be picked up, and patients are completely asymptomatic, have no symptoms whatsoever. Nisa, if you don't mind. So, there really are two main categories of pancreas cysts that are relevant to us, and I'll explain a little bit about what these are. The vast majority are what we call IPMN, intraductal papillary mucinous neoplasms, and we'll show you some pictures of some cartoons of what that means and what that looks like. And then the other category is a mucinous cystic neoplasm, and if you're looking at this closely, you'll see what both of these cyst types have, and what both of these lesions have in common is that they're mucinous cysts. Mucinous meaning sort of a sticky fluid that fills this cystic cavity. So the first category is this IPMN, intraductal papillary mucinous neoplasm, and so just kind of, the term actually, believe it or not, makes sense. And what this means is IPMN are cysts, are abnormalities that occur within the pancreas duct. So on this cartoon, similar to the one that Nisa showed earlier, the pancreas is this tan structure, and the green thing that kind of branches out to screen right is the pancreas duct. You remember that the pancreas does a lot of things. It makes insulin, it helps us control our blood sugar, but it also secretes enzymes, chemicals, juices that then go into the intestine and help us digest our food. And all those juices travel down that little duct and empty into the intestine. So we're talking about a problem with the duct, essentially. And what happens is that the duct develops these little projections, these little papillary projections. The cells that line that duct change, and they start to secrete mucin and start to secrete this material. And that's what an IPMN is. You can have IPMNs that replace the entire main pancreas duct. You can have IPMNs that are just sort of a little bubble off on one of the side branches of the duct. There are all sorts of variants of these kinds of neoplasms. And one of the things that we study is how those seemingly infinite number of variations of how big the duct is, how small it is, where it is in the what does the rest of the pancreas look like, where it is in the pancreas, how do all those factors impact the risk of these things turning into cancer. Next, please. The other kind of cyst looks very different, and so this is perhaps more of what that scan that we started off showing looks like, and this is called a mucinous cystic neoplasm. Once again, filled with mucin, but this is more of a big, solid kind of thing. These are really interesting neoplasms, really interesting lesions for a couple of reasons. Number one, they almost exclusively, some of us even think exclusively, 100% exclusively. I can tell you, I've never seen one of these in a man. These are almost exclusively in women. And very interestingly, if you look at these cells under a microscope, they look very much like the tissue that you see in an ovary, which is a very strange detail. We call it ovarian stroma. And there's got to be some clue in there that we're trying to study. These are far less common than IPMN. These also probably have a higher risk of turning into cancer. But these are the other major category of precursor lesions that we study. So I think this concept here, when we talk about this disease, I think this is really one of the really critical ideas. And we know from talking to Catherine and some of the other folks when they came and visited us in Dallas, I think you guys are more sophisticated than a lot of other groups. So I think it's okay to share some of this that's a little bit more scientific. I hope that's all right. But this concept that, cancers don't turn, cancers are essentially normal cells gone wrong. And cancers don't start in a normal cell, have a switch go off, and the next day they're cancer. It doesn't happen that way. It's this progression from normal to abnormal. And if there's one concept that really underpins what we're trying to do in the pancreas cancer prevention program, it's this idea of trying to catch lesions in this progress, in this, somewhere in this spectrum. In other words, identify, whether it be blood tests or imaging characteristics or symptoms that can kind of show us when people have a lesion, not that's way over on the right, that's a cancer, not that's way over on the left, that's normal, but a cancer that's in that middle category that's on its way to becoming pancreas cancer. That's really what we're trying to do, is identify cells in the middle of this progression. So what our general protocol is, and there's obviously a lot of detail that goes along with this, but it's sort of a 30,000-foot view. We have a big team, as Nisa mentioned, and patients initially are evaluated by our nurse navigator. Our nurse navigators are really the heart and soul of this program, and they get patients where they need to be. They get the right tests. They do all of that. We do a lot of work obtaining family history. Lots of things, lots of factors are relevant here. We would think about things like, obviously, if a person has a family history of pancreas cancer, but it's also very notable if they have a family history of breast cancer, for instance. So we track a lot of information. As they need it, we make sure they have the right imaging. If they need an advanced endoscopy test, like the one that Dr. Kabillian is an expert in, we do that. If they need an additional MRI, we arrange all that. And then maybe the most important element of this is that we all sit in a room. We sit there and we, at 11 o'clock once a week, and we just go through scans. And I think some of the people on this call had an opportunity to watch this. And it's a pretty, we're engaged in this. I mean, every patient, we look at their scan, and these radiologists who are looking at this are not hobbyists. These are people whose one of their primary academic missions is to understand pancreas cysts and what their scans look like. And so we spend a lot of time looking at those scans and making sure that we've really characterized each patient's lesion. And then they obviously see us in clinic or telehealth, and we counsel them on what needs to happen. And for the vast majority of patients, they don't need surgery. Many don't need an endoscopic ultrasound. Many of them we're just going to watch. And just like we do for patients who are being monitored for other risk factors for other types of cancer, whether it be mammograms in breast cancer or colonoscopies in colon cancer, we just put them on a schedule of following them with imaging. And what our home runs are, and I like to, point this out, our home runs are those situations, and we have many, where we identified lesions and we said that person has a lesion that is right on the cusp of turning into cancer. And we take them to the operating room and we remove that lesion. Oftentimes, Dr. Kabillion and her partners give us that key information that lets us understand that. But we take them to the operating room, we remove that piece of the pancreas, and I mean, it's just like I say, a home run moment when we get to tell those patients and their families that you didn't have pancreas cancer. If you'd let this sit for a while, for a year or two, you would have, but you don't. And that for us is a home run. There's so many opportunities for in discovery here. You know, new technology. We've developed a whole new way of looking at these MRIs, and our radiologists have developed specific protocols that let us look at these patients' pancreases. And then, as Dr. Kabillion said, you know, analyzing the cyst fluid, analyzing the blood, so that we can find even more clues to identify these patients early on in their disease. And so, I like this slide. Nisa put this slide in, and I like it because I think, you know, the concept here is, you know, what we really are hopeful is that we can come back, you know, in some period of time and come back and talk to you and tell you, you know, all the things we've learned about identifying patients who really, I mean, the truth is that probably many of these patients don't need this intensive surveillance. It'd be terrific if we could tell patients that your risk is not that high. But I think what we really want to do is identify that small percentage of patients who need an operation, who need some preventive surgery or some preventive treatment that can prevent them from ever having pancreas cancer. So I'll stop there. Once again, we are so appreciative of your support and your engagement and your participation. And I think Dr. Kabillion and I are both happy to answer any questions you may have.